Dr. Amin and Dr. Guha will be chairing this session. We have 3 talks in this session on CNS involvement in HIV. Thank you, sir. I hand over the proceedings to you. We like to keep the discussion at the end of the 3 sessions so that we can save on this time. Thank you.
Thank you. Let us move to our session 10 from the excellent ASICON 2025. And we have 3 speakers in this session. It's mind under C's and very specific deliberation for CNS involvement in person living with HIV. And with that, I think may I call upon the first expert, Dr. Hemant Patel from Ahmedabad. He is going to deliver on a ring enhancing lesion in the brain.
ASICON welcomes Dr. Hemant Patel. Dr. Hemant Patel holds significant positions, including Secretary of the Asian Oceanic Society of Radiology and National Past President of the Indian Radiological and Imaging Society. Dr. Patel is involved with work radiology and is the RSNA coordinator for the Asian subcontinent, demonstrating his international
comparison first and last conclusion.
He is the editor of a textbook on radiology and has numerous national and international publications showcasing his expertise and contributions to the field. Dr. Patel received the Best Radiology Entrepreneur Award in 2019 at the Health Express Radiology Conclave, recognizing his innovative contributions. With DMD, MD, DMRA and MBBS degrees, he has a strong educational background and extensive experience in radiology. We look forward to hear him talk on enhancing lesions and brain.
Wonderful afternoon, and it is my privilege to be part of ASICON 2025. Many congratulations to Gujarat State Chapter for hosting this conference of national caliber. I also acknowledge the contribution from Dr. Atul Patel, Dr. S.K.Guha for putting vast efforts for creating awareness and also mentoring so many youngsters in the field of infectious disease and HIV and AIDS related. They must have treated thousands and thousands of patients. Thank you all of that. It's a very interesting topic, CNS involvement and especially ring enhancing lesions in the brain. And this reminds me of the Lord of the Rings, the Fellowship of the Ring, and Are You the Lord of the Ring? And the lesions in the brain, many a time, they give in post-contrast T1-weighted MR, the appearance of a ring enhancing lesion. They may have the different characteristic, and on the basis of that, we may change the diagnosis. So the ring enhancing lesion, it may be infective lesion, it may be tumor, demyelination, and vascular disorders. MR especially is more helpful compared to the CT. CT is practically not giving much information except saying that there is some abnormalities going on. MR is the modality of the choice, and not only the conventional MR, but we need to have the advanced tool like diffusion weighted imaging, perfusion MR, SWI, MR spectroscopy. Using all these arsenals, we can finish the diagnosis. So which are the etiological factors, and to easily remember that mnemonics is a magical doctor. It's a metastatic lesion, abscess, glioma, infarction or inflammatory lesion, contusion, AIDS-related infection, especially toxoplasmosis and cryptococcus, lymphoma, demyelination and resolving hematoma. Though this is just for the remembering the thing and maybe more for the theoretical purpose, it's not in the order of common occurrence. When any patients or when you see on the MR ring enhancing lesion, you have to club up many factors, and these are the clinical features like the age, signs and symptoms, physical examination, medical history, whether the patient is compromised or not, and of course the radiological findings. So when you see any ring on the post-contrast MR, it may be thin ring or thick ring. It may be smooth or irregular. It may be the complete ring or incomplete ring. The lesion may be unilocular or the multilocular. Apart from ring enhancing lesion itself, we have to check for the center of the lesion, whether it is comprising of necrosis, pus, the blood, surrounding edema and mass effect. It also gives a lot of information. Whether the lesion is solitary or multiple, localization and distribution. For example, whether lesion is located into the deep gray matter, it's lying in the white matter, frontal lobe, posterior fossa, whether it is in the deep gray matter junction, they all tell about the underlying etiological factor, and of course the clinical history and the presenting symptoms. So, wall features or the ring enhancing wall, when it is thick and nodular, mostly we are dealing with the neoplastic lesion. When the ring is thin and regular, mostly we are dealing with the abscess. When there is the open ring, when you see there is the incomplete ring and the 20-30% portion of the ring is open, then mostly we are dealing with the demyelinating lesion. When there is the intermediate to low capsular intensity, then it may be abscess, and then all restriction on the DWI or the diffusion mediated, it may be demyelination or the GPM. So just purely on this knowledge alone, we can clinch many diagnoses. For example, here when it is the very smooth and complete ring and associated edema, mostly it may be the abscess. When you see the thick, irregular and very shaggy looking kind of the ring, it may be the tumor. When you see the incomplete ring, that 20% is left out, then this may be the demyelination. When you see such kind of the eccentric nodule within that, it may be the toxoplasmosis. This is the rough guideline for identifying the ring enhancing lesions. So on the basis of the pattern, we can tell whether it is abscess, glioblastoma, it may be the metastasis or the MS, and these all are the post-contrast studies, right? So we will go case by case, so that will give us the more insight. Here what we see, this is the T2 and the flare image, where we see the multiple discrete hyperintense lesions involving the supratemporal compartment bilaterally, frontoparietal lobes, and the lesions, they are showing the complete circular, well-defined ring enhancement, and on diffusion, there is the restriction of the lesion, right? So in the DWI, there is complete restriction of the given lesion of the ring enhancing, which is seen on the post-contrast MR. So which are the probable diagnoses? Whether it is the MADS, abscess, MS, resolving hematoma, anybody? Ring enhancing lesion, thin, it's a complete ring, associative diffusion restriction. So this is the classical case of the abscess, it's multiple abscess. Now, when you see the complete smooth, thin, unilocular ring, and when it shows the restricted diffusion, DWI is showing the complete restriction, it is most likely we are dealing with abscess, right? So, ring enhancing lesion, when associated with the diffusion restriction, then we are dealing with abscess by and large, right? So, this is the other case. Here you also see the thin, complete ring, and it's a ring enhancing lesion. This is the high V value or the diffusion weighted, where you see the restriction completely, and when you see the ADC is a different subset of the diffusion weighted image, and the same lesion, it appears dark. This is because of lack of the movement within the lesion, right? So when you see the diffusion restriction, we are mostly sure that we are dealing with abscess, and this pus is having the high viscosity and maybe having the inflammatory health, matrix protein, cellular debris, and the bacteria within, and that results into the diffusion restriction. This is very important parameter to identify cerebral abscess, right? The topmost sequence is the diffusion weighted. This is so specific. Even if you start with some antibiotic, whether the patient is responding or not, This is more specific than the pathological test also. You look at the ADC. If the darkness is getting now less, then patient is responding to that antibiotic, right? So check for the darkness in the ADC. If it is giving a response, then you are going in the right track for treating the patient. This is other case. You can see the multiple abscesses, diffuse restriction. You see on the ADC there is the dark, and this is very typical appearance of abscesses. So when you run the diffusion restrictions or the DWI, if there is restriction, then it's an abscess. If there is no restriction, then that suggests there may be some necrosis within the ring enhancing lesion, and now we may be dealing with the tumor, right? So the tumor here, raised appearance maybe look like ring enhancing lesion, but here there is one high B value, there is no diffusion restriction, this is the ADC, there is no darkness, there is the GBM, in the metastasis also there is no restriction, in demyelinating plaque or the MS, when the plaque is acute, then only there is restriction, otherwise there is no restriction. Another important parameter and the advanced tool what we can use to differentiate, that is the MR spectroscopy, right? So here again it looks like the ring enhancing lesion and we want to characterize them further. So in case of abscesses, if you put the MR spectrum, here what we do, we select the pixel within the center of the lesion and its graphical value will come from the machine itself. And now we plot them into the choline, creatine and NA, then after the lipid, lactate and all that. In cases of abscess, you see the lot of lipids, lactate and amino acid peaks. When you see such kind of the peaks, then mostly we are dealing with pyogenic abscess. So normally this is the MR spectroscopy, whereas the choline, creatine, NA in ascending curve. This is normal MR spectroscopy. In cases of abscess, you don't see choline and creatine in peak and these peaks. Instead, now you start getting the amino acid and the lactate peak, right? So here what you see is the lipid, lactate, amino acid, succinate and the acetic peaks, and this suggests that we are dealing with cerebral abscesses. This is the other case, very typical. Now look at this ring enhancing. Complete ring enhancement, you see the diffusion restriction, this is the high P value, dark one ADC, typical of cerebral abscess. When we run the MR spectroscopy, we find the lipid, amino acid and acetic peak. Look at the choline, creatinine and NA peak, they are completely suppressed. I go back and these are the, normally we find such kind of the peaks, but here in abscess, there is complete suppression of choline, creatine and NA. Instead, you see the increase in the lipid and the amino acid, and these were the cerebral abscess. There may be atypical cases of the brain abscess, and in our scenario, mostly toxoplasmosis and tuberculoma, they may create some confusion. How to differentiate? Here, in cases of toxoplasmosis, you don't see the diffusion restriction just like the pyogenic abscess. Instead, you may see such kind of the eccentric target sign, and this is because of the adjacent inflammatory changes within the vessel wall, and it's a mural nodule within the ring enhancing lesion. And in tuberculoma, you here see the lipid peak, and there may not be the significant restriction as compared to the pyogenic abscess. Here, 58-year male who presented with convulsion and MR shows irregular peripheral conglomerated lesions showing the ring enhancement, multiple lesions, adjacent edema. When we run the spectro, there was significant increase in the lipid component. Now, in tuberculomas, the lipid is the predominant component within the abscess, and because of that, we get the lipid peak, and this was the tuberculous abscess. In the same patient, we run the MR perfusion and there is the hypoperfusion. There is not much vascularity within the lesion compared to the tumor, and this was the giant tuberculoma. So this is the other case where we put the spectrum here and there is a significant lipid peak, and we are mostly sure that we are dealing with tuberculous abscess. Toxoplasmosis, here we get very typical concentric target sign. There are layers of round and round on the tumor and the tituated image, especially the tituated and the flare images, right? So here there are the concentric rings with the hyperintense and alternate hypointense signal. Alternatively, there may be associated perilesional edema. The size of the abscess is comparatively less than the pyogenic abscess. When you do the contrast study, in such cases, usually we get the ring enhancing lesion But additionally, we do get eccentric mural nodule which is adjacent to the wall, right? So this is the typical mural nodule, and that denotes this is the eccentric target site. So there are two sites for the toxoplasmosis. One is the concentric on titubated, and another is the eccentric target site on post-contrast shiver. And this mural nodule is extension from the abscess wall because of the inflamed vessels in its groove. So this is the another case. You can see the multiple lesions, but here you see the ring enhancing lesion with mural nodule because of the inflammatory vessel. Okay, this is the CT scan, and what we see here, there is the post contrast. We see the solitary lesion with complete circular ring enhancement, and there is also a central dot here. Patient presented with the convulsion. There was no fever, and when you see such kind of the scolex within the lesion, then the most likely diagnosis there is the it's a degenerating neurocystis or cyst, right? When cyst gets ruptured, it is associated with the perilesional edema. So the MR appearance may be variable according to the whether in the vesicular stage or the granular stage of the disease process. 68 year who had left-sided nephrectomy because of the renal tumor, now presented with the seizure. Anybody? Just look at the history and we can clinch the diagnosis. Ring enhancing lesion in the left frontal lobe associated with a lot of edematous changes. Anyone? Sorry? Metastasis, right? Because patient already operated for the renal tumor. So the diagnosis is easy in this case when we are having the history. If the history is not available, or maybe the unknown primary, then it may be the diagnostic dilemma. Here, so again coming back to the MR appearance, it's the complete ring enhancement, though it's a little irregular in the periphery. If you look at diffusion weighted sequence, here there is no restriction. Right, in the abscess we find this as completely bright and this is the dark, but here there is the no restriction. When there is no restriction, think about the necrosis, and when there is the necrosis, it's bad and it's usually the tumor, right? So in this case, it's a metastatic lesion, and you see the necrosis. So when you see no restricted diffusion, think of the necrosis. There is the round, irregular, well-defined margins, intense enhancement. Everything remains same. Only thing, there is no restriction on diffusion weighted image. Another case, 58-year female, progressive weakness, numbness, gait disturbances, and memory loss. What we see here, there are multiple discrete pinpoint variable sizes lesions in the periventricular, perivalvular white matter. They are perpendicular to the corpus callosum, and this is very typical appearance. Anybody? Female patients, middle age, and perivenular white matter lesions. I heard somebody said it's multiple sclerosis. So on the history and the appearance on the T2 and the flare, we can make out the diagnosis if you push the contrast. When the acute plaque, they are having this kind of the ring enhancement lesion. So if you look closely, this ring is complete here, but on the medial side, there is some break-ins, right? So this is the incomplete ring enhancement. So it's an open ring kind of the appearance. It's a very typical of multiple sclerosis, right? So there are multiple lesions, age, location, and open ring. Then we are sure about the multiple sclerosis, and there is no differential diagnosis. So just to make it more simple, this is the other case. You see the open ring kind of the enhancement. Location is the periventricular white matter, and it's a typical case of the demyelination or multiple sclerosis. 79-year female presented with motor aphasia and the right hemiparesis that started 15 days ago. So the scan is after 2 weeks of the episode, and what we see here, there are multiple lesions showing the peripheral enhancement, not circular, not well-rounded, but they are a little more irregular. They are discrete also in the basal ganglia and the subcortical and the galliform pattern also in the temporoparietal lobe. This is the diffusion weighted sequence and showing some of the areas showing the restriction, and there is some blooming also here on the SWI. SWI is a specific sequence, it's a susceptibility weighted sequence we run when we are suspecting especially any infarct of the hemorrhage. It is very particular to pick up any smallest hemorrhage inside the brain, So there is the susceptibility artifacts, it's the blooming effect. And here you see the restriction also. MR angiography, it is showing the tight, very tight stenosis and near complete occlusion of the M1 segment of the left middle cerebral artery. And there is the left MCA infarct in a subacute phase. When it is in the subacute phase, you see such kind of the serpentine enhancement, right? So here you see the thin, irregular serpentine enhancement. You may see the blooming artifact on SWI. Angiography may be showing the block, and this is a straightforward case of subacute infarcts on left MCA territory. 38-year male with history of HIV, altered mental status, and headache. What we see here? Large hypointense lesion on T2-weighted image associated with paralesional edema involving the corpus callosum, genu part. Anybody? And there is the complete ring enhancement of the lesion on post-contrast. HIV positive patient. CNS lymphoma, right? So, when you see the CNS lymphoma, it's a highly cellular tumor. So, T2 will show the dark appearance or the hypointensity. And because it is solid, there is not much movement within the tumor. It does show diffusion restriction, right? So, this is the DWI showing the mild to moderate restriction. It's a very classical appearance of lymphoma in a HIV positive patient. So these are other cases. Look at the typical appearance here. Again, there is the diffusion restriction. Again, you can see the peripheral ring kind of enhancement and the solid intrinsic component. 39-year female, headache, blood vision with cranial nerve palsy is here. There is the large tumor which is located in a cortex with a shaggy looking, dotty looking peripheral wall enhancement. There are also intrinsic tumoral nodular enhancement. When you run the diffusion, there is not much restriction of the tumor like the abscess, and probable diagnosis is a glial cell tumor like glioblastoma or gliosarcoma. And look at this thick, irregular shading in the margin, which is pointing towards such kind of the glial tumor, and there is the no restricted diffusion like the abscess. So here again, there is, because of the necrosis, there is no diffusion restriction. One more tool is there for identifying, and we can run the MR spectroscopy. So as I said, choline, creatinine, and the NA is the typical frontal line appearance, and in cases of the tumor, there is choline will be having the peak, creatinine will be the diminish, and again diminish NA. Right? So okay, so last minute, and we will wrap it up. So here you see the reversal of the peak. This is the another tool we are having in the other patient. We run the MR perfusion, and you see the tumor vascularity. This red area that is showing the hyperperfusion, and when you see such perfusion, we are dealing with the tumorous tissue rather than any infective etiology, right? So the perfusion also tells us about the lung. And this is the last case, 30-year woman with the headache. On T2, there are conglomerated lesions involving the brainstem. Post-contrast study, they were showing the peripheral enhancement, and we had dilemma on the tuberculomas, or it may be the developing abscess, but we were wrong, and ultimately it turned out to be Neurobacheck's disease, where you only need is the steroid therapy, and patient was completely cured. So to summarize the whole thing, pyogenic brain abscess diffusion weighted sequence is very sensitive, and perfusion, it shows the hypovascular. MR spectroscopy, there is the amino acid lipid lactate peak. GBM, or the brain tumor, where we see there is no diffusion restriction. Perfusion is on a higher side compared to the other lesion. Multiple sclerosis, they are usually perivenular. They may be having the open ring appearance, and there may not be the much perfusion. And lastly, about the AI and the machine learning, it is coming in a big way. Trust me, we just give the information to the machine. They will bounce back with so many narrowed down diagnoses nowadays. So we just write clinical history and the ring enhancing lesions with a clinical background, and they will pop up with submitting all the data of the post-contrast MR along with the spectroscopy perfusion. It's very exciting and very thrilling time is coming. So when we meet next time in some other conference, then we will talk about AI appearances and how it picked up so nicely and we had achieved the diagnosis. So to conclude the thing, ring-enhancing lesions of the brain remains a diagnostic challenge dilemma, including a wide TD of neoplastic and non-neoplastic lesions. MR stands as the main diagnostic imaging modality. MR spectroscopy, diffusion and perfusion MR, the image adds significant value to the precise diagnosis of ring-enhancing lesions. Thank you so very much.
Thanks for the excellent talk.
Thank you.
We'll take questions at the end of the three presentations. So we are now invite Dr. Franco for the session on HIV associated
ASICON welcomes Dr. Franco M. Buonaguro. Dr. Buonaguro is the Director of Molecular Biology and Viral Oncology at National Cancer Institute, Naples, Italy. His research has focused on the role of viruses, particularly DNA viruses like herpes virus and papillomavirus, in human cancers, especially CAPRISA, sarcoma and genital cancers, since 1983. In collaboration with the Uganda Virus Research Center and WHO, he conducted significant AIDS research, including biomolecular and phylogenetic analysis of HIV-1 isolates. Dr. Buonaguro has worked on developing an anti-HIV-1 vaccine using virus-like particles in a baculovirus expression system targeting non-HIV-1 strains prevalent globally. He has been deeply involved in addressing healthcare needs in developing countries, particularly through his work establishing and co-directing the ICSC World Lab East Africa AIDS Research Center in Uganda. We look forward in hearing him talk on HAND.
Good afternoon. Well, this is very peculiar presentation following the brain rings. It's very, very interesting. Anyway, so I'm going to talk about the HIV-associated neurocognitive disorders is it on? So, this is one of the latest review, which is showing the different types of neurodegenerative disorders. In particular, we have the one without asymptomatic neurocognitive impairment, the mild neurocognitive disorder, the dementia, and the mild but associated disorder with some motor damage. And so the differences among them, besides to be asymptomatic with the first and the other one all symptomatic, it depends on the type of involvement that we see in some mild neurocognitive disorder. In particular, there is interference with mild functioning, mild, and marked interference with the daily function of the dementia type. The first component, so the asymptomatic neurocognitive impairment, has been defined in 2007 with the Frascati criteria to identify this type without really neurocognitive dependency. HAND is common in the United States, and you can see that almost 50% of people with HIV, they do have some kind of neurocognitive disorder, symptomatic. And again, this is very relevant for the impairment when there is already at the baseline, the first visit. This is also common in other countries, for sure, including India, China, Uganda, and so on. The everyday consequences of AID is difficulty with finance and meal preparation, but also with medical adherence and short-term supply. Which are the risk factors? Well, there are host factors like AIDS, malnutrition, anemia, genetics, chemokines, insulin resistance, the age that Stefan was mentioned before, and non-host like the HIV neuroadaptation, the different strains, and co-pathogens like hepatitis C. The real issue is that with the Frascati component, so the one with the asymptomatic component, there is apparent an overestimation of end frequency associated with some type of test. So, for instance, we have that in Malawi, the asymptomatic component is over 50% by itself. And so, in the latest years, I am not sure whether I have to be with okay, doesn't matter. So, there is a need of revising these criteria and in order to identify much better the neurocognitive disorders, and again there are consensus recommendations for a new approach. One of the most relevant issue is the viral load in the central nervous fluid, and we can see that usually is associated in the fluid, the central nervous fluid, and in the blood. But in some cases, we do see higher frequency in the central nervous fluid than in the plasma. And for instance, we have that in some case, there is a much higher frequency in the cerebral nervous system than in the plasma. How happens something like that? Well, because various particles are going through the blood-brain barrier, and in this case, they are able to infect the macrophage or the glia, and indirectly to interact with the neurons. So this is just to show some of the possible way of diffusion. So once it's inside of the brain, then obviously we do have a release of molecules which can damage the mitochondria of the neurons and give some neurotoxic aspects. The end frequencies and pathogenesis started in very early, at the beginning of the epidemic in 1985, 86. But then the more relevant component of the inflammation was actually identified much later. And this component, so the inflammatory component, not only the direct infection, is something that is very similar to what has been reported in H1N1 influenza, or more recently in the COVID, so the component of the cytokines. So besides the direct damage of the neurons, by HIV rodents, particles, and so on, we have the associated chronic inflammation, which is increased by the susceptibility of age and potential neurotoxicity of some of the antiretroviral drugs. So the infection in the brains is very fast, is actually almost at the same time of the plasma. And we see also at the same time increase of some of the cytokines, which are obviously induced by infection. Something that is also interesting is that the neuroinflammation, not only the infection, so persists following the infection also despite the antiretroviral treatment. So the major issue is actually the presence of cytokines and other molecules. And the antiretroviral therapy has been changing its pattern because before we had the very almost 25% were associated with dementia, associated with, but only following a CART is very little component, probably less than 10%. So the antiretroviral therapy modified very much the acute, the severe dementia, while the asymptomatic and the non-symptomatic has been very much increasing following the ARC. The something else that is worsening the situation is that obviously in the general population we do see already a gradual decrease in the long-term memory, working memory, short memory. So it's only the verbal knowledge that is stable during the years. And this condition becomes much stronger during the HIV infection. Okay, and so in the older population, in any case, there is an increased risk of cognitive impairment. And this is mainly associated to the Alzheimer's disease. In fact, this is in Europe, for instance, where we see this is the vascular type of dementia, and this is the Alzheimer type, which is the most relevant, and we see in the male and in the female. This is also, for instance, in Spain, the low portion is for the vascular, and the other one is for the Alzheimer type. Similar results are also from other countries, not only Western Europe, but also, for instance, Japan, which is in the middle. We see in China, which is again from the 60 years or 17 years, all that is going up. And the same we see also in India. Well, actually, there is something that is interesting, but I probably am not able to really understand. Usually, the vascular component we have seen is relatively low. In the data reported from India, we see that the vascular type is actually almost the same of the Alzheimer type, and in 2014 actually was higher than the Alzheimer type. Then when we see the infection component, in the infection component we can see that almost half is HIV, but we have also very little of syphilis, and almost 25% is tuberculosis associated. And obviously in this aging population, HIV associated. We do see also the Alzheimer dementia that is going up. And what is very interesting is the type of molecular damage that we see. So this is reported for people living with HIV, and the two bars, one is for the amyloid beta, the first one. The second one, the bluish, is for the tau, and the difference between the lighter and the darker is the darker is the very focal spread one, and the lighter is the focal. So what is interesting is that this is in the people living with HIV. Instead, in the general population, no HIV, so we see that the progression to more advanced Alzheimer's disease is associated with the widespread precipitation of these two proteins, the tau and the amyloid. Actually, this is also very interesting considering the different distribution of the frontal temporal component in respect to other components of the brain, for instance, the basal temporal versus the hippocampus and so on, where we have the different distribution of these two precipitating proteins. Obviously, with the early antiretroviral treatment, the neurocognitive in some way got some subtle improvement in some cognitive tests, but not in all of them. So depending from the type of antiretroviral treatment, we had some type of improvement, considering that some of the antiretroviral molecules had very higher penetration score in the central nervous system compared to other like tenofovir, with the ability to transfer the bone marrow, the blood barrier was much lower, and this is what has been highlighted in these slides. So, as we can see, for instance, in any case, in the central nervous system, we have between 10 and 100-fold lower than in the normal, in the plasma. So, in any case, there is a difficulty to access the brain. And this is again to show that the frequency of dementia, in this case is the associated Alzheimer type, essentially is with the peak of a high viral load in the brain. And here this is also very, very interesting. So once we get the escape in the viral load in the brain, at that time the cognitive impairment goes up. So obviously there is a strong association between the brain infection and the disease. Now what is very interesting is also to verify the type of the comparison between hand and Alzheimer's disease. In particular, we see that, for instance, obviously the Alzheimer's disease is mainly associated to, it's not very simple to read, so I have to read here, but in the left, in the right side, in the Alzheimer's disease, you will see mainly the tau protein and the beta amyloid accumulation, while in the end there is a very little of the two proteins, is much less obviously. For the imaging, well, there are something that probably our neurologists would have better explained. And the clinical presentation are obviously the cognitive impairments and the significant memory loss of the Alzheimer's disease. So there are just some minor component that is shared between the N and the Alzheimer's disease, in particular the neurofilaments, the amyloid blend, and the inflammatory cytokines. And obviously these are the damages associated in hand, which they, as we said, are independent of the art treatment. Thanks for your attention.
Thank you, sir. We'll move to the last lecture of the session, and that is CNS tuberculosis by Dr. Kalpesh Sukhmani from Ahmedabad. Yeah. Welcome, Dr.
ASICON welcomes Dr. Kalpesh Suresh Sukhmani. Dr. Kalpesh Sukhmani is a consultant, Infectious Diseases, KD Hospital and Research Center, Ahmedabad. Dr. Sukhmani is a consultant specializing in infectious diseases. His field of interest includes infections in immunocompromised individuals, a critical area of concern. He is also focused on hospital epidemiology and infection control, highlighting his commitment to preventing healthcare-associated infections. Dr. Sukhmani has contributed to the medical literature with 8 publications in indexed journals on infectious diseases. We look forward in hearing him talk on CNS tuberculosis.
Very good afternoon, everyone, and thanks to organizing team for having me here. Not a core HIV physician. My practice involves 25% of my work is HIV, but I've tried my level best to review the best available evidence to discuss all the major important aspects of CNS tuberculosis here. This is a very common scenario which we see on day-to-day basis. This is a 55-year-old male who has a progressive weight loss in last 6 months, presents with intermittent fever, non-productive cough, and subsequently gets admitted with altered sensorium of 2 days duration. On examination, there is oral thrush, signs of meningeal irritation are present, hepatosplenomegaly, and blood workup reveals HIV test positive. CT brain shows meningeal enhancement, CSF has high cells, low sugar, and high protein, with ASB stain positive. This is a very common scenario we see on day-to-day basis. But when someone is dealing with this kind of case, there are a lot of questions which are need to be addressed here. Whether anti-tubercular therapy is to be started empirically, awaiting the workup, what are the other possible etiologies one has to consider in this kind of patients, what should be the best anti-tubercular therapy regimen in these kind of patients, what is the role of steroids or any other anti-inflammatory drugs which can be used, optimum timing of starting antiretroviral therapy, and taking care of relevant interactions along with important complications. When we talk of CNS tuberculosis, it is the most devastating form of tuberculosis, where meningitis is the most common presentation, but rarely we see arachnoiditis, tuberculomas, and abscess as well. In HIV, the presentation, treatment, and diagnosis remains same, but because of the ongoing immunosuppression, there is a high prevalence of other concomitant opportunistic infections, along with increased incidence of intracranial tuberculoma. And there is a lot of issue with interaction issue with ART and ATT, and not to mention fear of CNS iris, which is associated with poor outcomes. And that is why CNS tuberculosis in HIV has a poor survival rate compared to non-HIV setting. Add to it, there is a high prevalence of CNS tuberculosis in Asian continent, The prevalence, this is the data from last year, prevalence in Asia was found to be as high as close to 55%. It was more compared to Africa. And this is because of disturbance in the immune system caused by HIV. So in HIV, there's a progressive decline of CD4 count, which we know, which leads to difficulty in formation of the granuloma and hence containment of the tuberculosis. This leads to dissemination of tuberculosis and seeding into the meninges or the cortex. Plus, along with this, HIV per se can directly disturb the blood-brain barrier, which lets the tuberculous bacilli easily enter into the CNS, leading to easy access to CNS, leading to tuberculous meningitis. We also know from past the association of CD4 count and the prevalence of opportunistic infection. This is more relevant in tuberculosis, and we can see here as the CD4 count declines, goes lower than 200, the incidence of tuberculous meningitis increases sharply. And from the data from African studies in last 20 years, we can see that as the percentage of ART coverage in the HIV community increased, the incidence of tuberculosis-related death decreased. Along with that, the incidence of TB also decreased. So this also suggests the importance of HIV therapy also in controlling tubercular incidence and prevalence. TB meningitis, as we discussed, occurs more commonly when CD4 count is low. It can present in phases, a prodromal, meningitic or paralytic phase. Usually the CSF has a high opening pressure with higher WBC count along with low sugar and high protein. But when the patient is having advanced HIV, especially when the CD4 count is less than 50, low count CSF with normal protein and sugar can be seen. This can be easily confused with cryptococcal meningitis. Classic neuroimaging findings in tubercular meningitis consist of basal meningeal enhancement along with infarction in the middle cerebral artery distribution, commonly basal ganglia, and hydrocephalus. These are classic findings on MRI in more in non-HIV setting. In HIV setting, the exudates and the inability to form granuloma leads to more of meningitis appearance or many a time miliary pattern of disease. When we are thinking of meningitis in HIV, one must not forget close differentials like cryptococcus, which is more common in HIV setting than TB. Apart from that, histoplasma, syphilis, CMV, and rare pathogens like brucella should not be missed. Tuberculoma can present at any level of CD4 count. These tuberculomas can be asymptomatic when they are not associated with meningitis. Very difficult to diagnose unless imaging is done. You can be many times they are easily picked up on routine imaging for some other purpose. Now on MRI, they are typically less than 1 centimeter in size, and if they're caseating, they show remanagement. MRI spec can differentiate these lesions from other etiologies with the help of large lipid acetate peak. TB abscesses, when these same granulomas increase in size or conglomerate, they form TB abscess. Usually it is more than 3 centimeter in size. Again, MRI spec helps to differentiate it from pyogenic abscess. Usually it is symptomatic and presents with mass effect, can even present with systemic features like fever. Biopsy, brain biopsy remains essential diagnostic modality for tuberculoma and brain abscess, tuberculous abscess both. While taking care of patient with an SOL in the brain of tuberculous etiology, one should not forget close differential like toxoplasma, primary CNS lymphoma, and cryptococoma as well. CSF remains a cornerstone investigation when we are discussing tuberculous meningitis, and gene expert MTB has become a standard of care because of lower turnaround time and a higher specificity. But one should not forget gold standard tests like cultures in CSF and also in blood. One of the recent meta-analysis has found almost 45% predicted probability of picking up MTB in the blood in the setting of advanced HIV. Apart from that, we have rapid bedside tests like lipoarabinol tests. These are CAR tests, but which are not available in our setting. Conventional test has good specificity, but they lack in sensitivity, which can be increased if we increase the time on microscopy or increase the volume of CSF, stand for cultures or gene expert, with the help of centrifugation. The yield can be doubled and can help diagnose these patients earlier. While these cases are undergoing evaluation, many a times these patients, while going evaluation, are deferred from anti-tubercular therapy. This is a very interesting study which has studied 263 patients undergoing evaluation for suspected meningitis. Almost half of them were co-infected with HIV. And they studied outcomes in two groups. One who received early ATT and the other one who received later ATT. The reason for receiving late ATT was initial clinical suspicion for TB was less, but subsequently either TB got confirmed on culture after 3-4 weeks, or there was no other etiology found, and hence they were started on anti-tubercular therapy. They found that the survival was significantly associated with the early onset of anti-tubercular therapy, and hence I think any patient with a clinical suspicion of tuberculosis meningitis should receive anti-tubercular therapy as early as possible. The regimen for drug-sensitive TB in CNS tuberculosis, the major data comes from pulmonary tuberculosis and remains same. Apart from the conventional 9-month regimen, now WHO has also rolled out a 4-month regimen with rifampicin, which is also applicable to HIV patients, but not severely advanced disease. And in MDR TB, apart from 9-month and 18-month-old regimen, we have now a new 6-month BPAL regimen, which is also approved for HIV patients. But what more, in spite of giving appropriate anti-tubercular therapy and starting them on ATT at the correct time, there is almost 40% mortality in HIV setting. What more can be done? There is a lot of interest right now in improving TB meningitis outcomes with the help of two approaches. One is optimizing the TB regimen, because in HIV, as we discussed, it is very difficult to control the TB dissemination because of the because of the immune dysfunction. So the idea is to rapidly microbiologically cure tuberculosis with the help of increasing the dose of conventional antimicrobials which we are using, or adding new drugs like quinolones or hydroxyzonamide. On the other side, the major complications in tuberculosis are because of inflammation associated with tuberculosis, and hence host-directed therapies are of more interest right now. We have more data on non-HIV, but in HIV setting also the data is building up. When we talk about optimizing ATT, the standard 4-drug regimen, which we have been using for a very long time, is good, but the drug penetration is limited for rifampicin and ethametol. Isoniazid pyrazinamide has a very good CNS penetration, but rifampicin and ethametol does not. Along with that, there is a poor drug level achieved in the blood of these patients, which is compounded by the malabsorption, which is very common in HIV setting. So ethambutol and streptomycin have established limited benefit in tubercular meningitis, more of because of increased resistance rate for streptomycin and side effects, ethambutol because of penetration issues. Many centers use ethionomide, replacing ethambutol in TB meningitis, especially in the pediatric setting, and we have a very good RCT on this, and now WHO gives this regimen of ethionomide with high-dose rifampicin, pyrazinamide and isoniazid as an alternative regimen in pediatric TBM cases. WHO has approved this as an alternative regimen in pediatric TBM setting. Rifampicin, in spite of achieving poor drug levels, is known to improve the mortality in tuberculosis. This we know from data of MDR tuberculosis, and hence there is a lot of interest to retain rifampicin, but to increase the dose to optimize the efficacy. We already have good data in non-HIV pulmonary tuberculosis setting, where high-dose rifampicin at the dose of 35 mg per kg has shown to improve the microbiological cure in the cohort. And the same is being now studied in HIV in two new RCTs which are almost done. The data will be published in early 2026. One is Intense TBM trial and the other one is Harvest study, Both these studies are studying high dose rifampicin 35 mg per kg per day along with linezolid and levofloxacin compared to standard regimen to look for the mortality benefits. Trials of these data will be coming next year. Apart from this, aspirin is proven drug to as a secondary prevention for stroke in non-tubercular stroke cases. So there is a lot of interest right now to try aspirin to prevent stroke in TB meningitis cases, because stroke is associated with very poor disability-free survival. That is why aspirin has been more and more studied. This is a meta-analysis published from Chandigarh. They have studied 3 RCTs. The primary endpoint was mortality at 3 months, and the secondary endpoint was mortality associated with stroke at 3 months. They could not find a reduction in mortality when aspirin was used in the patients with TBM, but what they could find is that aspirin could prevent a new onset stroke in TBM patients, but the number needed to treat was 10. But again, these 3 RCTs had very limited numbers, less than 100 numbers in each RCTs, and aspirin is an anti-platelet which requires a lot of safety data. One of these studies did not include any safety data, and hence this is insufficient data and awaiting more clinical trials. Aspirin is still not recommended for preventing stroke in TBM. What about steroids? Steroids have a proven role in non-HIV tubercular meningitis setting to improve the outcomes in terms of less complications. But in HIV setting, this is a RCT published in 2023, where they enrolled almost 500 patients, half on dexamethasone side and half on placebo with standard anti-ATT regimen. And what they found was no difference in mortality and no difference in CNS iris among patients who received dexamethasone in HIV setting. Again, this study had almost half of the patients were having advanced HIV with CD4 of less than 50, and half of them were not even on ART. Also, dexamethasone dose was very low. It was tapered by the time the ART was initiated. Maybe that is why the number of paradoxical iris cases did not improve even in the group of dexamethasone cohort. Also, last point, this is not applicable to centers where mechanical dealing with the complication of TB like VP shunt is available. This study excluded the patients who underwent VP shunting for hydrocephalus, which is known to improve the mortality in TBM cases. So steroids in HIV, where to use? It is proven role in treatment of paradoxical CNS iris. Steroids also has a preventive role to prevent non-CNS iris, especially in advanced HIV, where CD4 is less than 100 and ART is to be commenced within 30 days. But in TBM, the roles remains limited for cases where there are warning signs present, like presence of basal meningeal enhancement, which is an impending marker for vascular complications, or there is a mass effect, which needs to be aggressively controlled, or there is a advancing hydrocephalus or spinal block. Steroids have a proven benefit role in TB meningitis in non-HIV, and this benefit is because of the increased concentration of inflammatory cytokines in the CSF compartment. When we talk about HIV, the inflammatory cytokines are much more higher in HIV patients, but the lack of steroid benefit in the HIV cohort has led to a thinking of establishing a role of more targeted anti-inflammatory agents like infliximab, thalidomide, and interleukin-1 inhibitors. There are only case studies or case reports for all these molecules right now in HIV setting, and the largest study is published from CMC Vellore by Amin et al. They recruited 90 patients of TB meningitis, and this was an observational study, and they have given infliximab to 30 patients along with ATT and steroid to the rest of the 60 patients. Indication for infliximab was optochiasmatic arachnoiditis or a focal neurological new deficit, whether it's paraparesis or upper limb paresis. And they found a combined, 6 months severe disability-free survival in the cohort who received infliximab. Although the numbers are very less, but this is very promising in the HIV setting. They had HIV patients also. They had 7 to 8 HIV patients recruited in this. When to start ART in tubercular meningitis? So early initiation of ART is definitely proven to improve outcomes when we are talking about non-tubercular meningitis patients, non-neuronal TB cases. But in CNS TB still guidelines recommend to defer ART for 4 to 8 weeks, and the reason being two studies. One was the RCT published in 2011 where they found a higher incidence of severe adverse events in the early ART group, along with no difference in the mortality at 9 months. And then subsequently one study got published, which was a prospective study where they found a higher incidence of TBM iris in these patients who received early ART. But these are very old studies, and the studies in the INSTI era is still not available. A lot of these TBM group patients who are under evaluation for TBM are deferred early ART because of the fear of iris. I think this Ramachandran et al. Has published this data with the help of metagenomic sequencing. They found 17 different pathogens in these suspected tuberculous meningitis patients in HIV setting who were deferred ART, and subsequently were found to have other pathogens. So I think metagenomic sequencing, I don't understand this sequencing thing a lot, but it definitely has got role in patients where early ART is to be initiated and which is deferred because of the fear of tubercular meningitis, which is a clinical assumption. When we talk of interactions, we have a lot of interactions with rifampicin, but among NRTIs, most of them are safe, including TAF now. TAF is being a substrate of P-glycoprotein, undergoes induction with rifampicin, and hence the exposure is reduced in the presence of rifampicin. But now there is data that intracellular TAF concentration is still higher to achieve the cure. Efavirenz is the best NNRTI studied among the NNRTI group with rifampicin. INSTIs undergo reduction in the exposure in the presence of rifampicin, but can be easily managed by doubling the dose. PIs are contraindicated with rifampicin because we need to at least 4 times double the PI dose because of the induction of the rifampicin, and hence best drug is to attribute rifampicin. There are a lot of other ART drugs, newer ART drugs which undergo interaction with rifampicin. One must be very careful with them. Betaquilin, can I get 1 more minute? So bedaquiline again has a lot of interactions. In the presence of PI, bedaquiline undergoes a lot of increase in the dose, which can be very lethal because of the potential side effect of QT prolongation. NNRT has a reverse effect on bedaquiline, which leads to reduction in the steady state of bedaquiline. But the current line, first line INSTI-based regimens are not affected and can be easily used with bedaquiline. So there are broadly 3 strategies to manage drug-drug interaction in HIV setting. Either replace the rifampicin with rifabutin, which has limited access, or use ART without clinical significant interaction like efavirenz, but again the efavirenz has a lot of neurotoxicity and lower genetic barrier to resistance, that is why best avoided. And that is why dolutegravir-based regimens have become standard of care when we are dealing with TBM patients, where we can double the dose of dolutegravir. Interestingly, study done at Botswana, the patients who did not receive the second dose of dolutegravir could manage virological load in the absence of second dose of dolutegravir as well. This was further confirmed in a phase 2 randomized trial where they showed a single dose dolutegravir compared to double dose dolutegravir in the presence of rifampicin could control viral load at 24 weeks. Bictegravir goes more induction compared to dolutegravir with rifampicin, but now we have data for bictegravir also. Bictegravir can be doubled just like dolutegravir and used in the presence of rifampicin. We have data, 24 weeks data with good viral load suppression from INSIGHT study. Lastly, the complications of TBM, hydrocephalus and hyponatremia. One must be very careful while managing these complications. A careful decision for deciding on the surgical procedure, whether it is a ventricular-peritoneal shunt or endoscopic third ventriculostomy, should be done with the neurosurgery team. Hyponatremia, there are 2 basic mechanisms, but in spite of the cause of the mechanism, hypertonic saline is recommended for all these patients with the close monitoring of the infusion rate to avoid the demyelination complication. So take home to conclude, ATT should be started as early as possible to improve the outcomes in TBM patients, especially in HIV setting. But one should be very careful in ruling out other post-differential diagnosis. And many times we have concomitant opportunistic infection which should not be missed, like cryptococcus. steroids definitely have benefit in non-HIV setting, no major role in HIV unless and until there are warning signs present. There is an evolving role of infliximab. Now we have data in HIV also, although the data is limited to case series. ART should be started early in cases where the tuberculosis meningitis is not confirmed, because all the data and the guidelines which recommend 4 to 8 weeks of deferral of ARTs for the confirmed tuberculosis meningitis, not for the empirically treated or thought of subacute meningitis. Relevant interaction should be always taken care of when rifampicin is on board, and high dose rifampicin and antiplatelet most probably will get data next year from intense and harvest study and will be able to apply it, but that data is promising on high dose rifampicin 35 mg/kg. Thank you.
Thank you, Dr. Kalpesh, for the excellent talk. Now the floor is open for a few questions.
So I think post-lunch effect, if there is no question, we can hand over to further proceeding to the
Yes.
organizers.
Thank you so much. I would request our chairs, Dr. Bipin, Amin and Dr. Guha, to hand over a token of appreciation to our speakers. Dr. Kalpesh Sukhmani. Dr. Franco. Dr. Franco. And Dr. Hemant Patel. Okay, Dr. Hemant Patel had to leave, so we'll give him his token later. I also request Dr. Harsh Toshniwal to hand over a token of appreciation to our chairs for this session. Dr. Bipin, Amin and Dr. Guha.